Hey everyone, welcome to this exam-focused explainer on biotransformation. If you're prepping for your MD pharmacology exams, whether that's tackling those brutal theory papers or gearing up for a high-pressure viva, mastering drug metabolism is just absolutely non-negotiable. I'm going to guide you through the core concepts today, really breaking down the biochemistry into easy-to-remember, highly testable chunks. Okay, let's dive right in. We've got 5 core sections to cover today. The basics of drug metabolism, Phase 1 and the CYP450 system, Phase 2 conjugation, the super high-yield topic of enzyme inhibition and induction, and finally, clinical significance. Starting off with Section 1, the basics of drug metabolism. So if your examiner asks for the core difference right off the bat, you've got to be precise. Biotransformation isn't just about literally destroying a drug, right? It's about modifying it so your body can get rid of it. The key takeaway here is that Phase 1 chemically modifies the drug's structure. Think of it as adding a tiny biochemical handle through oxidation, reduction, or hydrolysis. Phase 2, on the other hand, simply conjugates it. It basically grabs onto that handle and attaches a bulky, water-soluble group. Look at it like this. Phase 1 reactions are your functionalization phase. Because you're exposing or adding reactive groups, you end up forming products that are chemically reactive. Sometimes these are active metabolites, and sometimes they're actually highly toxic. Now, Phase 2 is the synthetic or anabolic phase. By attaching a large water-soluble molecule like a sugar or an amino acid, you generally create these inactive, highly polar products that your kidneys can just flush right out in the urine. So Phase 1 alters, and Phase 2 tags and bags for excretion. Moving right along to Section 2, Phase 1 and the CYP450 system. Okay, the exact mechanism of the cytochrome P450 monooxygenase system is honestly fascinating. And for a guaranteed mark in your theory paper, you'll want to write out these exact steps. It's called a monooxygenase for a very specific reason. The system takes a molecule of diatomic oxygen, O2, and with the help of NADPH and a flavoprotein reductase, it essentially splits that O2. One oxygen atom goes to hydroxylate the drug, basically turning DH into DOH, while that second oxygen atom is reduced to form water. It's just an incredibly elegant biological machine. Now, these CYP enzymes are heme proteins, and their naming convention is something you need to know. The root CYP is followed by a number for the family, a letter for the subfamily, and another number for the specific gene. But here's the good news. While there are 57 human CYPs, you do not need to memorize all of them. Just remember that families 1, 2, and 3 really do all the heavy lifting. They literally mediate up to 80% of all Phase 1 drug metabolism in clinical practice. You'll want to take a mental screenshot of this mapping of key CYP isoforms to their specific drug substrates. It's an absolute must-know for your exams. For instance, CYP1A2 is your go-to for caffeine and paracetamol. CYP2C9 is absolutely critical because it metabolizes warfarin, which, as you know, has a notoriously narrow therapeutic index. Then there's CYP2D6, famous for its genetic polymorphism, affecting how different patients convert codeine to active morphine. And CYP3A4? Wow, that is the absolute giant of the liver. It handles over half of all prescribed drugs, including things like statins and calcium channel blockers. Let's slide right into Section 3, Phase 2 conjugation. So, as we said earlier, Phase 2 involves attaching a substituent group to the drug. The big one to know here is glucuronidation. You absolutely must memorize UDP glucuronic acid, or UDPGA, as the high-energy donor compound, and the enzyme UDP glucuronyl transferase is what facilitates that transfer. Other critical pathways to keep in mind include sulfation, methylation, acetylation, which, by the way, is highly prone to genetic polymorphism, so think of your fast and slow acetylators, and finally, glutathione conjugation. That one acts kind of like a cellular fire extinguisher against reactive toxins. Now, here is the crucial point for a Viva question: the exceptions. Examiners absolutely love asking when Phase 2 actually creates an active metabolite. A great memory trick for this is M&M, minoxidil and morphine. The sulfate metabolite of minoxidil, which we use for severe hypertension and hair growth, is actually the active form. Similarly, when morphine undergoes glucuronidation, it forms morphine 6-glucuronide, which is a potent, fully active analgesic. Always, always remember the exceptions. All right, on to Section 4, enzyme inhibition and induction. This is arguably the highest yield topic because it directly dictates patient management. You really need to compare the clinical timelines here. Enzyme inhibition causes an immediate decrease in metabolism. Literally, as soon as the inhibitor reaches the liver, it blocks the enzyme, creating a rapid, high risk of drug toxicity for any co-administered substrate. Enzyme induction, however, involves synthesizing brand new enzyme proteins, so it's a delayed acceleration of metabolism, taking days or even weeks. This can lead to slowly developing therapeutic failure or even autoinduction, like when you start a patient on the anti-epileptic drug carbamazepine and you have to slowly titrate their dose up. Let's break down the exact mechanisms of P450 inhibition. It can be competitive, like quinidine competing for CYP2D6, even though it's not a substrate itself. It can be non-competitive, where a drug like ketoconazole binds really tightly to the actual heme iron of CYP3A4, just completely shutting it down. But if your examiner asks for an example of suicide inhibition, where the drug is oxidized into a reactive intermediate that covalently binds to and permanently destroys the enzyme, your absolute go-to answers should be the oral contraceptive gestodine or the anthelmintic diethylcarbamazine.
And finally, Section 5, Clinical Significance.
This is where the textbook theory hits the hospital ward, right? These clinical takeaways are essential. Think about enterohepatic circulation. A drug is conjugated in the liver and excreted into the bile. It enters the gut, where intestinal bacteria essentially cleave off the conjugate. That reactivates the drug so it can be reabsorbed right back into the blood. This creates a loop that drastically prolongs the drug's effect. You also have to account for pre-systemic or first-pass metabolism, which can really shred oral bioavailability. And of course, there's the ever-present danger of phase 1 toxicity. Which leads us directly to a classic, totally unavoidable exam scenario. What exactly happens biochemically when a patient presents to the emergency room with a paracetamol overdose? Here is the exact mechanism you must write down. At normal doses, paracetamol is safely conjugated by phase 2 pathways. But in an overdose, those phase 2 pathways become completely saturated, so the excess drug is shunted over to phase 1, specifically to CYP1A2 and CYP2E1. These enzymes oxidize paracetamol into NAPQI, and NAPQI is a highly reactive, incredibly dangerous phase 1 metabolite. Normally, hepatic glutathione neutralizes it, but in an overdose, your glutathione stores are rapidly depleted, leaving that NAPQI free to covalently bind to liver proteins, causing massive, potentially fatal hepatic necrosis. This perfectly summarizes why phase 1 biotransformation is kind of a pharmacological double-edged sword. It is absolutely necessary for clearing fat-soluble drugs from the body, but the very act of making them reactive opens the door to severe toxicity and cellular damage if your secondary defense systems fail. So as you wrap up your prep, consider this. Learning these pathways isn't just about passing an exam. How are you going to leverage this profound understanding of CYP variants, inducers, and inhibitors to prevent fatal toxic drug interactions in your future patients? Keep that in mind as you study. Good luck with your exams and keep diving deep into the pharmacology.